In this chapter, we will discuss therapeutic relationships in the psychiatric setting. In psychiatric nursing, there is a strong emphasis on the interpersonal aspects of nursing that draws influence from Hildegard Peplau and other theorists in the cognitive, behavioral, and social sciences. Your assessments are less focused on the numbers, technical skills, and machines connected to the patient, and more focused on the person's current state of mind and well-being, the influences of the environment and people surrounding them, and how they react, adapt, or not adapt to life's circumstances. Building a therapeutic relationship with a patient is the foundation of psychiatric nursing and the vehicle that drives patient care. Without this, it would be difficult for the nurse to achieve accurate and thorough assessments and facilitate interventions. It could also be difficult for your patient to feel safe and supported. To provide context, you might be caring for a patient who has significant paranoia, and without a therapeutic relationship, the ability to assess and provide care may be compromised. So what differs a therapeutic relationship from a personal one? In our personal or social relationships, there usually is a mutual gain from both sides, such as friendship, socialization, exchanging stories, and giving advice. Therapeutic relationships are different in that they focus on the patient and what they can potentially gain from it. Our contribution is the uniqueness of ourselves, understanding of the human physical and psychological condition, and other traits to help the patient move forward with their recovery and healing. We take on various roles in the relationship listed in your textbook, such as counselor or a resource person. Establishing a therapeutic relationship with the patient is one of the best predictors of positive outcomes in treatment. Some of the things that this can accomplish are the patient feeling more safe and supported. Safety is the priority in psychiatric nursing. Without a sense or a feeling of safety and security, it would be hard to allow oneself to be vulnerable and allow people to help you. An established or working therapeutic relationship can provide that safe space for the patient. It can facilitate communication of thoughts and feelings. A lot of patients can struggle with communicating their own thoughts and feelings, and we are there to help clarify and explore this with them. This can strengthen our understanding of their situation and provide a more accurate assessment. The patient can also benefit from this interaction as they may learn more things about themselves than they did before. It can help assist with problem solving. Patients sometimes need our help in figuring things out, whether in the short term or the long term. The nurse works with the patient and encourages them to think for themselves instead of thinking for them. It can provide an opportunity to explore self-defeating behaviors and test alternative behaviors. Patients sometimes learn ways to cope with aspects of life that can be maladaptive or hurtful to themselves or others, and this can make their interpersonal relationships hard to keep. Establishing a therapeutic relationship can lend itself to exploring what these maladaptive behaviors or defense mechanisms might be doing for them and finding a more positive alternative to getting that same need met. It can help promote the patient's self-care and independence. Although it's in our nature as nurses to help patients, that doesn't mean patients can't do things for themselves. Our definition of help can mean encouraging the patient to do things for themselves to the extent of which they can manage at any given moment. For some, this may be more of a long-term goal that we can also help break down to smaller, more attainable steps. Providing education about medications and managing symptoms of their diagnosis. There are a lot of good and bad information out there that speaks to our duty to having an understanding of what the patient knows about their diagnosis and what gaps need to be filled. And it can help facilitate future nursing interventions that can contribute to the patient's continued healing, learning, growth, and recovery. Depending on the patient, therapeutic relationships can occur instantaneously or take time to develop. In reality, sometimes nurses don't have the uninterrupted 30 minutes or an hour to spend on their assigned patients each day. So balancing the established and potential workload that you may be given on any shift may mean small, meaningful interactions and gestures that can start developing this. Like staff nurses, nursing students may struggle with the boundaries between personal and therapeutic relationships because there is a fine line between the two. In fact, students often feel more comfortable being a friend because it is a more familiar role, especially with patients close to their age. When this occurs, though, students need to make it clear to themselves and the patient that the relationship is a therapeutic one. Therapeutic relationships are based on legal, ethical, and professional standards led by the nurse for the patient's protection. When these boundaries are threatened, it can look like under-involvement, as in the cases of neglect or abandonment, or over-involvement, as in sexual misconduct, boundary crossings, such as when we disclose too much personal information, and boundary violations, such as when the nurse's needs are being met rather than the patient's. In some situations, we or the patient may act on something that triggers a familiar feeling or experience, which risks the blurring of roles. Countertransference and transference are defense mechanisms wherein a person unconsciously transfers or displaces feelings towards another, usually because it reminds them of someone from their personal lives. For example, maybe your patient reminds you of your grandmother who you were very close to growing up. You may start talking or treating this patient in a similar fashion to how you treated your grandmother. If the nurse is experiencing this, it is called countertransference. How can that look like? Maybe you find yourself spending more time with them, giving them special attention over your other patients, or withholding important information that should be shared with the rest of the treatment team. So what's wrong with this? It could be nothing necessarily, but it can be helpful to be aware and mindful if you are put in situations that risk crossing the therapeutic boundary and how you should handle it to maintain the relationship in a professional way. On the other hand, the patient may treat you a certain way, whether or not they realize this, because it reminds them of someone in their personal lives. And this is called transference. It may help the patient explore this, or if they're not in the space to, you may need to take the lead, such as setting limits or boundaries to keep their relationship therapeutic. Setting limits or boundaries can be saying something like, "That is information I'm not comfortable sharing. I'm happy to discuss with you anything about your treatment." So we know now what it is and what it isn't. How do we accomplish a therapeutic relationship? Just like with any relationship that develops, it takes time, an understanding of what's important to and for the person, and interpersonal skills. Therapeutic communication techniques is one of the tools that can help facilitate a therapeutic relationship. When used, it can help develop a better understanding of the patient's experience, and it can also help develop the patient's problem-solving skills and introspection. It is a different way of communicating that doesn't come easy or natural. It requires frequent practice and application to various situations. It's not a one-size-fits-all, such that a communication technique used in one scenario might not work in another scenario. I almost look at therapeutic communication as a dance of words. You have to guide the conversation based on the response of your patient at that moment. In Chapter 7, we review therapeutic communication in more detail. Therapeutic use of self involves using our unique talents and personality traits in ways that can contribute to our patient's healing, establish relatedness, and connection. Sometimes for younger or inexperienced nurses, connecting with their patients may seem intimidating because maybe you have no idea what you could possibly have in common with them. But with time, finding common ground with patients different from you becomes less challenging. You can begin to connect with your patients by offering kind gestures such as a smile or a handshake if appropriate. Maybe you are naturally a curious person and can ask about their interests, hobbies, and talents. Maybe you find humor is healing and know when to use it appropriately. Or maybe you're empathic and are attentive to signs of emotional and physical distress. These traits of being humorous, curious, and empathic may be a part of you naturally, but can also be brought to the relationship in a therapeutic way. Self-awareness can be an important tool for your personal and professional development. It helps you develop a better sense of what is important to you and can drive your actions and inactions. The Johari window can be a good place to start, especially identifying possible reasons why we think and act the way that we do. Putting these into awareness can help us understand our personal limits and how that may come up for us during our patient interactions, whether therapeutic or non-therapeutic. We have the choice to act or not act on them. Without this conscious effort, we may eventually find ourselves feeling burnt out, highly anxious at work, or creating unintentional barriers to patient care. We also must consider other factors necessary to enhance the therapeutic relationship. These are rapport, trust, respect, genuineness, and empathy. Establishing rapport is a mutual acceptance between two people characterized by trust, understanding, and a non-judgmental attitude. There is a genuine interest in others and their well-being, not based on labels such as that patient or their diagnosis. Rapport is one of the primary tasks of relationship building. So, for example, it would be difficult to establish trust without building rapport. The amount of time spent with a patient is not as important as what the nurse does with that time. Being consistent, helping problem solve, and providing support are ways to establish and maintain rapport. Trust is an important component towards developing rapport. In others, trust needs to be earned. These can be actions that show you are reliable, honest, and care for their overall well-being. Respect, or unconditional positive regard, is the belief in one's dignity and worth, regardless of their differences and behaviors. This is mainly communicated indirectly by attitudes and actions rather than words. It can look like active listening, or being fully present with the patient, holding on to our own judgments on the patient's choices, and exploring their thoughts and feelings that influence their behavior. You still treat the patient as any other person and not define them by their maladaptive actions or their diagnosis. Being genuine includes our ability to being ourselves or bringing a quote-unquote real part of yourself into the therapeutic relationship. I think a lot of people can sense when someone is being genuine or just going through the motions like a robot. So this can mean that the way that you carry yourself, interact with the patients, how you show you're truly listening and communicating, give others an impression of your genuineness. Approaching each interaction with a sense of curiosity can help the nurse genuinely understand the patient's perspective. Sometimes it may call for a degree of self-disclosure on part of the nurse. For example, your patient is your age and asks you about nursing school. It's okay to briefly share your general views on nursing school. This can increase your relatedness or bring you down to a more genuine level. On the other hand, questions about your personal life should be redirected, such as, "I'd like to focus on our conversation about what's going on with you." Talking about everyday topics can also spark some common interests and relatedness. Empathy is the practice of attempting to understand the other's perspective by putting ourselves in their shoes. So you might ask yourself, if I was in this situation, how might I feel? Or maybe you really don't know how it would feel like, and so you ask the patient or you let them know, I can't imagine what you might be going through. Or maybe you have experienced something similar to their situation and you can recall how you felt during that time. For example, a patient tells you that their pet passed away last night and starts crying. You personally have experienced that too and share the same feeling. You might consider starting off with saying something like, "I've been through that before. You'll get over it." Or, "There's other dogs that are looking for a happy home. Maybe you should adopt." Or maybe you just apologize for their loss, which would communicate our sympathy to their situation. But all of these can come across as either maybe minimizing their feelings or sounding too cliché, and might prevent the patient from opening up to you. So to make this a little more therapeutic, you can first think about the common feelings you felt during your personal experience. Then put this common feeling into an empathic response, such as, "It must be really hard losing a pet. Do you want to talk about it more? How have you been coping with this loss?" These statements validate their experience and keeps the focus on the patient without bringing our own experience into it or making it about us, and it elicits more information from them. So building a therapeutic relationship is an interactive and evolving process. It takes time, goes through phases that have specific goals and tasks or actions. We act as facilitators to ensure the relationship moves through each phase. In the pre-interaction phase, the nurse has yet to meet the patient. Here, they might explore their self-perception. In clinicals, this might be right after you get report and do your chart review. You're collecting all of this information to develop a sense of who this patient is. This is also a good time to explore how the information is settling with you and if there are any extra preparation you need to do. In the orientation phase, the nurse introduces themselves to the patient and starts establishing rapport. The goal for this phase is to establish trust and formulate a contract for interventions that have the expectations and responsibilities of the healthcare team and the patient. Exploring how will the patient participate in their treatment if they're able to. In clinicals, you may see posters in the common areas of the patient units that lay out their responsibilities, such as they must report any safety concerns that they see, or to respect the personal boundaries of others, or what type of clothes are appropriate or not appropriate to have on the unit. This may be discussed when they are first admitted or when their condition is improving. Our initial assessment occurs during this phase, and we start to formulate priority nursing diagnoses and goals. This phase also includes preparation towards termination to set the expectation and time limit, such as when they'll be discharged or when their legal status or legal hold will end, and help set the boundary that there is a limited engagement to this relationship. The working or maintenance phase can be the longest phase where we promote patient change through our nursing interventions. So we may see or hear progress from the patient. The patient may gain more insight and knowledge of their disease with our help. In the inpatient setting, we may or may not see this, and if we do see it, it will be in very small changes due to the short nature of the interaction. But in long-term care facilities like Crestwood, where patients stay for months or years, we could see improvements and regressions. There is ongoing assessment and evaluation of the individual towards their goals, helping them understand their treatment, medications, and managing their symptoms. Transference and countertransference can be common during this phase as well, such as the nurse giving advice or encouraging the patient's dependence. In the termination phase, the patient's progress towards their goals are evaluated. As they may need continued care outside of the inpatient setting, plans for preventing further decompensation can occur, such as perhaps attending outpatient group therapies, or individual therapy or family therapy. For some patients with certain diagnoses, deeply rooted feelings of loss, abandonment, loneliness, and rejection can resurface and result in the use of defense mechanisms or regression. I had a patient diagnosed with dependent personality disorder that had a scheduled discharge date. They were informed about the date in the days leading up to it and felt they were ready to go. On the day of, we noticed their behaviors drastically changed, and they remained in bed the whole morning, declining to get out and do anything. Usually, this patient would be helpful and near staff all the time. Recognizing this drastic change and considering their diagnosis and history, I spoke with them and started off noting the change in the behavior. There was a period of silence, which allowed some time for them to think and respond. Eventually, they responded that they didn't know. And so I kind of took a wild guess. I empathized with how difficult it must be to leave a place where possibly they felt safe and supported by the environment and the staff. The patient nodded, which opened the door to further discussion. The patient ended up being a little more amenable to discharging that day. So it's important to allow the patient, even though they are displaying these kind of behaviors, allow them the opportunity to explore and talk about some of the underlying feelings associated with what we are seeing. Sometimes patients don't know where it's coming from, but to have that discussion with them could bring out that as a possibility. If it's necessary, it could mean also reminding them about the time-limited interaction of the hospitalization or the clinical interactions.